Hello, and welcome to today's symposium on the changing landscape of treatment options for metastatic urothelial carcinoma. I'm Ashish Kamat. I'm professor in the Department of Urology at MD Anderson Cancer Center in Houston, Texas. And I'm really pleased to be joined by two excellent faculty, friends and colleagues of mine, but experts in their true right. Dr. Arjun Balar, who's Associate Professor, Department of Medicine at the NYU Grossman School of Medicine in New York, and Dr. Peter O'Donnell, who's Associate Professor of Medicine, Section of Hematology Oncology at the University of Chicago in Illinois. Welcome, gentlemen.
Thanks for having us.
So the agenda for today is essentially going to be three topics going to be presented. I will cover briefly the overview of the molecular subtypes of urothelial carcinoma. Dr. Balar will then discuss the safety and efficacy of immune checkpoint inhibitors in patients with metastatic urothelial carcinoma. And Dr. Peter O'Donnell will then discuss the efficacy and safety of ADC and enfortumab vedotin in patients with metastatic urothelial carcinoma. We will have questions and cases in between and a brief discussion as well. So let me start off by talking about the molecular subtyping of bladder cancer. This is a hot topic that often gets discussed and talked about not only in podiums and presentations, but also at the end of a lot of clinical trials when people are trying to make conclusions as to how can we predict response to different agents. So it's important for us, especially today in 2020, to recognize and realize what molecular subtyping actually means. These are my disclosures. None of these really are relevant to this topic per se, but I do advise companies that are working in this field. So to start off, a little bit of the background of the bladder cancer genesis. It was conventionally thought, and still is, that there are two main pathways by which bladder cancer develops. The 80% superficial or non-invasive low-grade tumors, and then the 20% going into the non-papillary, the CIS that could progress to invasive or directly into invasive as well. But clearly, this is a very simplified version of the genesis of bladder cancer. And not understanding more about the heterogeneity of bladder cancer has impeded our analyses of molecular mechanisms, biomarker development, and discovery of novel therapies. And hence, of course, we've moved away from the simple two-pathway hypothesis of bladder cancer genesis. Molecular subtyping does provide a framework to advance on all these fronts. So let's talk about gene expression subtyping and the conversions of the different subtyping schemes. So essentially, this was first published back in 2012 by the group from Sweden and Gottfried Sojal's group. Then this was elucidated by the TCGA, the Cancer Genome Atlas project. And then there were other groups, such as those from UNC, MD Anderson, ours itself, and many others that came after that. So the first group that looked at this was essentially the Lund group, and they divided their bladder cancers based on gene expression profiling into several groups, essentially squamous cell-like, urobasal, and genomically unstable were the two main categories, or the three main categories, and then they had an infiltrator category as well. The TCGA, in their comprehensive workup, then identified four main subtypes of bladder cancer, and these were divided based upon the various mRNA subtypes, as you can see here on the right-hand side. And I'll go over these in a little bit more detail, but suffice it to say that these four subgroups of bladder cancer were then replicated in some ways, and I say replicated loosely because some of these came out simultaneously, but they were sort of identified again by different subgroups, including the MD Anderson group, which identified three main subgroups. The red is the basal cluster, the blue was the luminal cluster, and the green was the P53-like cluster. Not P53 protein, but P53 gene expression profiling. And you can see that the two main clusters, that's cluster 1 and cluster 2 and 3, separated fairly significantly when it comes to disease-specific survival, but it was not an all or none type of phenomenon. And if you line these up together, you can see that the UNC, which was basal luminal, the Curie, the MD Anderson, the Lund, the TCGA, they all sort of line up in a way that replicates the bladder cancer subtyping of basal, luminal, luminal B, and claudin-low subtypes of cancers. And this is important because we are all doing these gene expression profiling in some ways, learning from our colleagues in the breast cancer field. This was first published way back, gosh, it's almost 2 decades now in Nature, showing the different subtypes of bladder cancer. And those of us that work in breast cancer, and those of us that work in bladder cancer can clearly see that even today we do follow these broad subtypes of luminal and basal. And in breast cancer, clearly they moved the field forward to a point where they actually use subtyping combined with HER2 staining, of course, to actually direct therapy for their patients. So based on this, there was, an attempt to actually classify these patients with the different subtypes. This is the TCGA 2014, TCGA 2017, and make some treatment recommendations. This was, again, an expansion of the TCGA subtype, trying to refine these into treatment recommendation subgroups. And then other groups came in as well and started doing meta-analyses of the published data, try to come up with different subgroups that essentially, to be honest with you, confuse the field a little bit. Not to commend them on their effort, but the fact that many people were coming in and trying to make subgroup connotations and denotations to guide treatment was a little bit confusing. So the groups came together, and in 2020, this was published, but this happened a few years before, came up with a consensus molecular classification of muscle-invasive bladder cancer using the data from 1,750 patients in 18 different data sets. And this was done in a well annotated fashion, and of course, using all the appropriate safeguards and safeties to make sure that this is replicable by different groups. So essentially what this consensus classification does is identifies basal squamous as one large subgroup, the luminal papillary as another one, then you have the luminal unstable and the luminal non-specified. At one end of the extreme, you have the neuroendocrine-like feature subtype, and this is a smaller group, but a very significantly different group from the rest. And then in between, and this sort of overlaps a little bit with the P53-like subtype that we found at MD Anderson, there's a stroma-rich group of patients. And using this, you can clearly see that they do separate out into different groups based on their oncogenic mechanisms, their mutations. For example, the luminal subtype of patients have FGFR3 positivity. The unstable ones are more P53, PPAR gamma, and the basal squamous are EGFR positive, of course, P53RB, and do have different immunoinfiltrates. This is the neuroendocrine, and even though it's a broad bar here, you can see it's only 3% of the total population. And these clearly fall off into another group that has significantly different prognostic and outcomes when you look at their behavior. So now moving into, can we use molecular subtyping today? Is it more than just a research tool? Can we use it to guide therapy? Well, one of the first things you can do is try to use subtyping information to guide staging. And the bottom line is luminal tumors are usually more likely to be organ confined in most series that are looked at. This is work that was done by a consortium led by Dr. Lotan from Dallas. And it looked at the value of luminal versus non-luminal and identifying the organ confined nature of the tumors based on TURBT subtyping and final cystectomy subtyping. Interesting paper. Obviously, it's not a clear all or none. You can see the p-values do kind of fall close to 0.05 in some instances, and in some instances are significant. But the bottom line is sort of here. You can see that the luminal subtype on TURBT tend to be more organ confined than the non-luminal, and this holds true even in multivariable analyses. And then they did a cancer-specific mortality, which was really not the purpose of the study. We again see that the luminal patients tended to do a little bit better than the non-luminal type. And again, this was independent in some ways of the upstaging at radical cystectomy. And this is work that was done again by the same consortium, published just recently, that shows that you can use the luminal type positive characteristics of subtyping to essentially identify a prediction both in the training set and the testing set of organ confined versus non-organ confined. And this then does translate into proportion surviving, overall survival at radical cystectomy, clinically, as well as based on the luminal versus non-luminal subgrouping of these patients. The next question that comes up, and I think is very relevant in some ways to this topic today, is can we use subtyping to guide the use of neoadjuvant chemotherapy? And here again, I draw your attention to the different subtypes: the luminal papillary, luminal non-specified unstable, forming this end of the subgroup, the stroma-rich, the basal squamous, and the neuroendocrine-like features. And as I've mentioned earlier, the oncogenic mechanisms, the mutations, the presence or absence of B cells, all of these, as we know, do help in some ways, at least provide hypotheses as to which group of patients might or might not respond to particular therapy. In general, though, if you think about it, and this is work that was done by David McConkey and Choi from MD Anderson, the luminal patients and the P53-like patients tend to, in general, have a better overall prognosis than the basal patients. If you look at the response to neoadjuvant chemotherapy, there are more responders, however, in the basal subtype as opposed to the P53. And the luminals tend to do well in general, so they have fewer fewer responders, but their overall response is better. And this was work that was not only performed at MD Anderson, but it was also validated by other groups, including Betsy Plimak using the Box Chase cohort. Now, what a group did, Ronald Seiler, using a consortium and looking at different subtyping, looked at essentially 4 classifications of these subtypes and found that in a group of patients that did not receive neoadjuvant chemotherapy, as I mentioned earlier, the patients with luminal subtype tended to have a better overall outcome probability. But in patients that received chemotherapy, you can see that this group here, the basal subtype of patients, then moved up to here, overlapping with the luminal. Now, just to emphasize, these are not the same patients that did or did not get chemo, of course. This is not a pre versus post. But in general, it seems to suggest that even though the luminal subtype of patients have a worse prognosis without chemotherapy, they respond better to chemotherapy, and then you can move them over to having a similar prognosis. You can see here in this graph at the bottom, 77.8% comparable to 74.7% with the luminal subtype with chemotherapy. So this gives you some indication that we might be able to use subtyping to sort of guide which group of patients get neoadjuvant chemotherapy. Now, what about neoadjuvant immunotherapy? Clearly in IMINGRA 210 with the TIZO, people looked at this, and at that point it seemed like basal clusters had the highest prevalence of IC23 PD-L1 positivity, but the highest response was seen actually in the luminal cluster type 2. This is based on the old TCGA subclassification into 4 main clusters. But if you then looked at Checkmate 275, it appeared that the basal cluster of patients actually did a little bit better. And of course, these are caveats of small numbers and different classification systems and PD-L1 status identification. Using the TCGA 2017 classification and then reanalyzing IMvigor 210, again, sort of the same stories seem to hold true, which is essentially that the patients who were in the luminal subtype tended to look like they would have slightly better survival probability than the basal and the others. But of course, these curves, even though they follow the p-value that's significant, don't really separate out too much. Now, Andrew Necki has actually done work with his PURE cohort, the PURE 1 cohort that looked at neoadjuvant pembrolizumab before radical cystectomy. And in this group of patients, what he did was looked at the PURE cohort and then compared them with a matched cohort that had neoadjuvant chemotherapy, essentially. And we all know the data here that the patients who got pembro in a neoadjuvant fashion did tend to have a fairly good response when it comes to PT0 rates of about 37%, which is comparable in many ways to what we see with neoadjuvant chemotherapy. And when he looked at the consensus subtype, which is here, and you can see, it looks like, again, the story holds true in some ways, that you don't really have a consistent pattern between what's been reported before and what's reported now. It does appear that in the complete responders, there is a higher preponderance of patients with a basal type of bladder cancer subtype, and not so much when it comes to the non-responders. But again, caveats of small numbers, and I think we really are a long way away from being able to say if you can use subtyping to predict response to immunotherapy. So in summary, our understanding of the molecular biology of bladder cancer is growing rapidly. Molecular subtypes based on gene expression analyses are reproducible across centers and multiple patient cohorts. We know that now when we have subtyping that can be used reliably. They do build a foundation for further discovery of disease mechanisms, for hypothesis generation and testing, of course, for identification of clinically relevant biomarkers, and of course, for targeted therapies. So bringing us back to this consensus definition, because I think this is in some ways becoming the de facto standard, and then looping in a publication from 2017, we can sort of broadly base our understanding into, well, the two types of bladder cancer tumors, luminal and basal. The luminal are usually GATA3 positive, FOXA positive, basal squamous are negative, and then the luminal can be subdivided into luminal papillary, luminal non-specified, and luminal unstable. The infiltrated did break out here into kind of stroma rich and non-specified. But if you follow this classification, it does appear that there is some way in which you can at least hypothesize treatment options for these patients based on the subtyping. And it's nowhere more clear than in the neuronal subtype, where clearly these patients, even if they don't have pathologic features of small cell carcinoma or neuronal carcinoma, clearly respond better to etoposide and cisplatin. But in the interest of time, of course, I'm not going to go into that in too much detail. So that's the end of my talk, and I do want to open up with a little question, and I've kept it simple on purpose. The question really is, should subtyping be performed today to make treatment decisions for urothelial carcinoma? And the options are, is this true or false? And let me open up to my panel for the response, and I know they'll get it right, but mainly for a discussion. So Arjun, what do you think? Can we use subtyping today to make treatment decisions?
So as of May 2020, I think the answer is no. So I think the answer is false. You've covered a lot of interesting topics, and we are doing a much better job now of understanding the molecular subtypes. What we're also recognizing is that the more you analyze in terms of the specimens, you start digging deeper into these molecular subtypes, as evidenced by the more recent analysis by the TCGA. And then what we also are dealing with is plasticity between subtypes. Sometimes treatment can influence plasticity, but sometimes the tumor itself, through a variety of mechanisms, it can do it itself. So right now, I would say the answer is false.
Peter, do you agree or disagree?
I agree, but with the caveat that I think we actually are using it in a way already. For example, it's very helpful to know that if a patient is going to have an enriched tumor for an FGFR3 alteration, which is actually identifying one of the subtypes as you so very, very clearly described, and if we know something like that, it directly leads to a treatment choice and may actually lead us away from another treatment choice like immunotherapy. And so those are one way that we are using it right now.
Yeah, it's interesting you mentioned that because actually, I'm sure you're aware, a publication just came out, I think a couple of days ago from the group that did the PURE study, suggesting that FGFR3 positive patients responded better in their group to immunotherapy than not. So this is, again, I completely understand your point about performing the subtyping in order to understand what's going on with the patient. And then if you have a clear targeted therapy, which both of you will sort of talk about a little bit, then we can make treatment decisions. But would you agree that the answer on the boards, for example, for your fellows, should be true or false for this question?
False here.
Yeah. And I'll just add one thing on top of what Dr. O'Donnell talked about, is that absolutely FGFR3 testing has identified a target and we have drugs for it, but that's DNA somatic alterations, right? When we talk about subtypings, I think we're classically talking about gene expression signatures, which are RNA, and those can be plastic, right? But I agree with you, once you have an activating FGFR3 mutation, that's part of the tumor, and it will be with that tumor for the life of that tumor usually.
Very good distinction to make, and I'm glad you brought that up, Arjun. Great. Okay, so moving on, we're going to have Dr. Arjun Balar talk to us about the role for immune checkpoint inhibitors in metastatic urothelial carcinoma.
Thanks so much, Dr. Kamat, for handing it off to me. And in my next 20-minute segment, I'm going to be talking about the role for immune checkpoint inhibitors in metastatic urothelial cancer. Here are my disclosures. And so anytime we're talking about checkpoint inhibitors, we're talking about obviously, modern therapy in advanced disease, which has really evolved over the last 5 years. But you can't talk about that without giving a little bit of perspective and historical context to how we used to treat this disease. And this slide more or less summarizes where we were for the past 30 years up until the advent of checkpoint inhibitors. We have classically thought of urothelial cancer as a chemotherapy-sensitive disease. What's listed here are the number of agents that have been tested over the years, initially beginning with single-agent clinical trials going back to the 1970s and culminating with combination-based treatments, which basically leverage the highest response rates that we saw with individual agents, with like cisplatin and methotrexate, which had higher response rates as single agents. And much of what we did then, as we do now, is that we take the best drugs we have and start combining them. And that was the basis for combinations such as MVAC and CISCA, and then more recently GemCis. What we recognized is that a small proportion of these patients, it's probably more like 10% or so, that can actually be cured with cisplatin-based therapy. And we can say that because not only did we have complete responses with cisplatin, but we had also the long-term follow-up that was necessary to prove that a patient could be potentially cured. And again, these are going back to combination trials that are in the late 1980s. What we also learned across all of these studies is that cisplatin-based chemotherapy is associated with substantial toxicity. And in fact, easily 50 to 60% of our patients may not be eligible for cisplatin-containing chemotherapy, generally out of concerns of toxicity, which identified a group of patients for whom we had to develop better options. Nonetheless, regardless of what patients received in the first-line setting, carboplatin or cisplatin, survival prolonging therapies did not exist in the second-line setting until the advent of checkpoint inhibitors. And so we basically counseled patients that after failure of platinum-based chemotherapy, best supportive care alone was a very reasonable option, and median survival was often in the range of 4 to 6 months. But standards of care are rapidly evolving in metastatic urothelial cancer. We have so many clinical trials, essentially beginning in 2014 or so, that have validated immunotherapy as a concept in bladder cancer. The biology has really compelled us to use checkpoint inhibitors, and the trials have demonstrated that these drugs are active. The initial approvals were in the second-line setting, 5 different agents targeting the PD-1 pathway, which are either PD-1 inhibitors or PD-L1 inhibitors. And then checkpoint inhibitor monotherapy more recently has been approved in the first-line setting, again, specifically for those patients who are cisplatin ineligible, although more recent trials are suggesting that maybe these drugs are also active in cisplatin eligible patients as well. And then more recently, we've kind of already touched on this, but FGFR rearrangements, FGFR2 and as well as FGFR3 is a biomarker. We can test for it in a CLIA fashion, and patients are eligible for FGFR targeted therapy, erdafitinib. And then also in December 2019, the very first antibody drug conjugate targeting Nectin-4 was also approved, and Dr. O'Donnell will be talking about that agent in his talk. Why do we use checkpoint inhibitors in urothelial cancer? Because it is a mutationally driven cancer. Carcinogen-induced tumors, such as lung cancer, melanoma, head and neck cancer, these are classically developed over many years, in fact, and chronic carcinogen exposure generally leads to higher mutational complexity. And then the more mutational complexity there is, the more likely that one of those mutations will generate anti-tumor host immune response. And what this plot shows basically is that the tumors on the far right are the ones that generally have higher mutational burden. The ones on the far left are other human cancers that have far lower. And you can see that bladder cancer is one of the right-sided tumors. How do checkpoint inhibitors work? Well, specifically PD-1 antibodies and CTLA-4 antibodies target the suppressed T cell that has been previously recognizing antigen. So starting from left to right, you can look at block number 1. And what this really describes is normal activation of a naive T cell. So you have an antigen presenting cell that presents antigen in the context of a class 1 MHC molecule, and it binds a T cell receptor that hopefully recognizes that specific antigen. And then you also have co-stimulation with the B7 receptor along with CD28 on the surface of the T cell. And you need both of these interactions to take place. And in fact, if you don't have that second stimulatory signal, you get T cell anergy. But this is normally how T cells get activated. And what they will then do is target any cell that is expressing that specific antigen. What happens shortly after that interaction is that CTLA-4 is upregulated on the surface of the T cell, and it competitively binds for B7. And this actually allows us to suppress immune responses, and actually is a natural break in the system that we have to prevent overactivation of the immune system. And so that's in cartoon number 2. Essentially what tumor cells do is co-opt that entire system. And what they can do is either leverage the CTLA-4 pathway to suppress immune activation, or also what happens upon the development of a antigen-specific T cell is to upregulate a protein called PD-L1, which binds the PD-1 receptor, which is also overexpressed on activated T cells. It's actually a marker of T cell activation. And what that generally lends to do is that the T cell then becomes suppressed. Now, we have blocking antibodies against both of these proteins, and what they do is allow the immune system to proliferate and also suppress T cells to be reactivated to generate an anti-tumor immune response. So the agents are quite extensive, and it first began with the very first phase 1 study that was presented at ASCO in 2014. What you have there on the left is a spider plot, and each individual line is an individual patient. And what you see is about a third of patients who were treated with, in this case, it was atezolizumab, which is a PD-L1 antibody, generated rapid responses, generally at the first scan, and many of these responses were quite durable. This was the initial presentation, and there have been updates to the original phase 1 showing that these responses, in particular, complete responses, can be quite durable for many years. On the right, you have the agents that have been tested subsequently. Each one is either a PD-1 antibody or a PD-L1 antibody, and the ones that are highlighted in red are the ones that have achieved approval, either through the accelerated pathway or the full approval pathway. The very first trial to be conducted to achieve approval was atezolizumab. They were kind of first on the block, and it began with a study called IMvigor210. It was a 2-cohort study focused on patients with metastatic urothelial cancer. The second cohort, which was the primary cohort in the study, were patients who were previously progressed on platinum-based chemotherapy. And as you remember, second-line therapy in bladder cancer before checkpoint inhibitors essentially had no survival prolonging therapy. And so therefore the FDA decided that a single-arm trial was reasonable to achieve accelerated approval, and ultimately the approval would be based off of the safety, the response rate, and the duration of responses through the study. So 310 patients were treated on this particular trial, platinum refractory metastatic urothelial cancer with atezolizumab 1,200 milligrams every 3 weeks until loss of clinical benefit. There have been many presentations and updates to this particular data set. I think I always pull out this particular slide because it tells us a very important lesson. This is a swim lane plot. A swim lane plot represents individual patients who have achieved a response to treatment. So each line is an individual patient. The green arrows represent ongoing responses, and all of the yellow dots on the left reflect time to response. So the most important kind of takeaways from this, and is emblematic of agents that target this pathway, are that responses tend to be early on, as evidenced by all of the yellow dots that are kind of stacked to the left there. And essentially these represent the very first scan. But there are also some patients who will have what are called delayed responses. So initially they have some minor regression, then ultimately they achieve a response. And what that reflects is that the immune system is a dynamic process, and sometimes immune activation takes some time, and one can generate an immune response sometimes later in the course of treatment. The individual arrows, again, represent ongoing responses and reflects that once you get the immune system going, in general, the immune system can continue to target the tumor and maintain and adapt with the cancer, unlike chemotherapy, which generally develops resistance sometimes after a few months of treatment. So that was an accelerated pathway. Ultimately, the FDA approved the drug. The response rate was around 15% on that particular clinical trial. But ultimately, we also needed to compare it to an active treatment. And that's where Keynote-45 comes in, a very similar trial design, metastatic urothelial cancer that had progressed after a platinum-based chemotherapy regimen. And patients here were randomized to, about roughly 542 patients were randomized to either pembrolizumab, which is a PD-1 antibody, versus dealer's choice chemotherapy, which at the time, for patients who wanted to receive treatment in the second-line setting, was single-agent chemotherapy. Usually in the United States, we use taxanes. In the European Union, vinflunine is allowed to be used. And so patients are randomized to really show, can we improve survival? What does the response rate look like? What does safety look like? And also, importantly, quality of life metrics as well. This data set in the primary analysis was presented, I believe, at the SITC meeting in 2016, and then has been subsequently updated many times. And what the survival plots reflect are a couple of things. Number one, at the primary analysis, which was at 14 months of median follow-up, the hazard ratio for survival was 0.73 and strongly favored pembrolizumab. But it shows is that at more than 2 years of follow-up, the hazard ratio actually improves and drives down further to 0.70. And what it shows us here is, and it's kind of reflected in the survival plots here, is that once the separation occurs between the two treatment arms, it can be certainly maintained because patients who receive immunotherapy tend to have durable responses. And so that's what we see here. So rather than covering all of the individual agents, this summary table really gives us a sense of exactly where these responses sit in the second line setting. What you have are responses in the range of 15 to 20%. Each agent either targets the PD-1 or PD-L1 pathway, but importantly, pembrolizumab did achieve full approval on the basis of a randomized phase 3 that did meet its primary endpoint. So now we focused initially on second-line disease. Now let's pivot and talk about first-line setting. 2 approvals, and I'll kind of cover them quickly here. So let's go back to originally what I was talking about, which is what is the role of cisplatin in muscle-invasive and also metastatic urothelial cancer? And that is to remind ourselves that cisplatin improves survival, potentially some cures. But as I mentioned, a substantial portion of our patients cannot safely receive cisplatin-based treatment. Performance status and renal dysfunction are the most common reasons. However, neuropathy, hearing loss, and also heart failure are also considered relative contraindications to receiving cisplatin. And what we know about these patients is that outcomes are very poor. Registry data from the Southeast have shown that up to 40% are actually never treated and never even counseled about their treatment options when they're presenting with advanced disease and are deemed to be not eligible for cisplatin-containing chemotherapy. And what you have on the right are the survival curves for the previous standard, and to a degree is still the standard, is gemcitabine and carboplatin, which has a survival of roughly 9 months. And as you can see from the survival curves here, essentially a long-term survival that is 0. So it was in this context that IMvigor210 also focused on a cisplatin ineligible cohort. This was kind of a secondary thought as part of the trial. It actually began first as 30-patient treatment cohort that expanded to target over 100 patients after we saw some of the activity that we were seeing in the second-line setting. So 119 patients were treated with first-line atezolizumab. And these patients were specifically cisplatin ineligible. What's highlighted there on the bottom left square are the definition or the criteria that define patients who were ineligible for cisplatin-containing chemotherapy. And these are patients who either had a poor performance status, impaired renal function, neuropathy, hearing loss. And so if you had any one of those, you were considered ineligible for cisplatin and then therefore eligible for this particular trial. We learned a lot from this study. We recognized that over 21% of the patients were above the age of 80, which again reflects that this is a disease of older individuals, and there are many patients who are octogenarians, and even now I'm noticing nonagenarians who are willing to receive treatment and want treatment for their cancer, however, do not want chemotherapy and are in many instances not eligible for any chemotherapy. And so what this data set shows is in the primary analysis, the objective response rate was 23%. We saw responses across immune subtype, PD-L1 expression subgroups. I haven't really talked about that just yet, and I'll save those slides for later. But PD-L1 expression is a biomarker. The more you have, the more likely the treatment will work. But it's not a hard and fixed biomarker, which means that even if you're absent of expression, then patients can still achieve a response, and that's evidenced by the 21% response rate in patients who were IC0. What the survival plots on the right show, these are broken down by PD-L1 expression levels, and the survival curves here show that the median survival was roughly 15.9 months at our initial analysis. And in a single-arm trial, median survivals are difficult to interpret, but I think the most important takeaway is that there's a flattening of the curve. And these are patients who are achieving responses that are durable and are living with their cancer, unlike before, where gemcitabine and carboplatin was associated with such poor survival. These were updated in 2018. That flattening of the curve is still maintaining. The 2-year overall survival rate is 41%, which is quite remarkable considering the outcomes that we would typically expect for this population when they're treated with gemcitabine and carboplatin. What clinical subgroups show is that there's definitely some patients who do not do well, and what we're recognizing is that in particular patients who have visceral and liver metastases in particular, these patients have very, very poor outcomes. Thankfully, we have an antibody-drug conjugate called enfortumab that Dr. O'Donnell will be covering that is quite active in liver metastases, but nonetheless, single-agent checkpoint inhibitors have very poor responses in patients with liver metastases. Finishing up with pembrolizumab, this was a very similarly designed trial to IMvigor210 cohort 1, except for one very important distinction. It was a much, much larger trial, roughly 3 times larger, at targeting 350 patients. Very similar eligibility criteria. Patients were treated in a single arm trial, just like cohort 1 of IMvigor210, with this time pembrolizumab, 200 milligrams every 3 weeks. 42% of patients were PS2. 49% of patients were above the age of 75. And what this tells you, again, is that there's a whole group of patients with advanced bladder cancer who are not eligible for cisplatin chemotherapy and for whom this type of treatment is very, very attractive. So the primary analysis that we published in the Lancet in 2017 had a 24% response rate for patients at the time of the analysis. And a little bit of a busy slide, but there's so many kind of take-home points here. Number one on the right is that the swim lane plot for this particular trial, very similar to what we have seen with other checkpoint inhibitors. All of these responses generally happen very early, and all of these red arrows indicate ongoing responses, which is very typical for checkpoint inhibitors. The waterfall plot, which reflects the depth of responses for patients, tells you that even beyond just the patients who achieve the 30% threshold for an objective response, there's still a number of other patients who achieve some regression in their cancer and generally actually enjoy a better quality of life because they've received treatment. So the proportion of patients who benefit is actually quite larger than just the patients who achieve an objective response. Dr. O'Donnell had updated our data set in 2018 and also and showed that actually with longer follow-up, we had actually a 5% increase in objective response at a 29% objective response rate. Again, reflecting that with ongoing treatment and ongoing follow-up, stable diseases convert to partial responses, and even partial responses convert to complete responses. And this is something that we just don't see with chemotherapy. I referenced before, and I'll kind of mention one of the strengths about this particular study is that it was much larger, 370 patients. And when you have a study that is that large, you have the opportunity to look at clinically relevant subgroups. In particular, PD-L1 expression was analyzed, and what we see is that PD-L1 expression as measured as the CPS score, which stands for combined positive score, when it's 10% or greater, you see a median survival of 18.5 months. And that is quite striking, and I hope that ultimately in KEYNOTE-361 we will see similar data. But what it tells us is that these patients generally have a very good prognosis. The response rate, which I don't have on this slide, was around 47% for PD-L1 overexpressing patients. And it tells us that this is actually a clinically useful biomarker in the clinic. And so that brings me to one very important update that happened in the summer of 2018, is that while both of these drugs were initially approved with a broader label for first-line treatment in patients who have metastatic urothelial cancer that were cisplatin ineligible, it had to be modified. And the reason it had to be modified is that, remember, these were single-arm studies. And no matter how large a single-arm study is, it's really difficult sometimes to know if there are clinically relevant subgroups that may have been better off receiving alternative treatment. And those patients can only be identified in the setting of a randomized trial. So in comes 2 important trials, IMvigor130 as well as KEYNOTE-361, which showed, and those particular studies were 3-arm trials. One of the arms was immunotherapy alone, and patients who were randomized to immunotherapy alone that had PD-L1 underexpression, okay, which means that low levels of PD-L1 expression, they actually had worse survival compared to patients who were receiving chemotherapy. And for that reason, the FDA label was modified for both of these agents, restricting its use to patients who were PD-L1 overexpressors, so CPS greater than 10 for pembrolizumab, and IC immune cell expression of 5% or greater for atezolizumab, or for patients who were not eligible for any platinum-containing chemotherapy. And these are classically the late octogenarians and nonagenarians. These are the patients who can't receive any chemotherapy safely at all. PD-L1 expression, this slide is useful. I borrowed this from a colleague of mine, Tom Powles, who's presented this at GeoAsk in 2018, and it's just a really good slide that highlights some of the performance characteristics of the various PD-L1 screening antibodies. What is kind of striking here is that in the same cancer specimen, that the tumor cell expression and the immune cell expression of PD-L1 across these staining platforms is relatively uniform. A little bit of an outlier is SP142, and you can see this here. So the staining thresholds are a little bit different, and so that's why, especially with the SP142 assay, they're not really interchangeable. However, they do reflect the same thing, which is that at the end of the day, immune cell expression or tumor cell expression of the PD-L1 protein, the higher the levels you have in general, the more likely patients will respond to PD-1 targeted therapy. So this is where we are now with the use of these agents. Atezolizumab, objective response rate of roughly 24%. And the update was we presented at a 41% 2-year OS rate. And pembrolizumab, the actually long-term follow-up is currently in press right now. Objective response rate of 29%. But again, we have to restrict its use in PD-L1 overexpressors or for patients who are not eligible for any platinum-containing chemotherapy. It would be terrible if we didn't cover safety, because it is important. The immune-related adverse events are this kind of generalized term for all the toxicities that patients can develop when they're receiving immunotherapy. And the importance of this slide is essentially that the immune system can touch any organ in the body, and therefore what's listed here are the various organs that can be affected over time with the use of immunotherapy treatments. Some basic guidelines about how we manage immune-related adverse events. We have in clinical trials the common toxicity criteria of adverse events, and what that does is it allows us to identify a toxicity and grade it based on severity. And when we do those things in clinical trials, then it then translates as part of our standard of care and guidelines that we use once the drugs become commercially available. And so grade 1 and grade 2 are generally mild toxicities. In some cases, grade 1 patients have no symptoms. It's just a laboratory or radiographic abnormality. Grade 2 generally are patients with some symptoms. And what we generally like to do is intervene when these symptoms first appear. And what we have learned going back a decade or more is that the earlier you intervene when patients develop an immune toxicity, the better off the patient will be, and we prevent higher grade toxicities. And so intervene at grade 2 so you can prevent a grade 3. In general, corticosteroids are the mainstay of treatment. About 1 milligram per kilogram a day of prednisone or equivalent is where we start. And we taper the steroids over the course of a month, okay? And that's because you don't want rebound symptoms to occur. The immune system is quite activated, and once it gets activated, it takes time to calm itself back down. So that's important to recognize. Higher grade toxicities are grade 3, grade 4. Grade 5 means that the toxicity led to death. And if unfortunately a patient develops a grade 3 toxicities, we have to do higher doses of corticosteroids. Some patients need intravenous steroids and need to be hospitalized. And then what's listed in the brown box there are some organ-specific interventions that we may need to do to intervene for higher grade toxicity. So anti-TNF therapy with infliximab, very useful in immune-related diarrhea and colitis. Mycophenolate and other agents can sometimes be used for immune-related hepatitis. And so, and in general, when these types of toxicities occur, you're definitely getting your specialist on board to help you manage the immune-related adverse event. So this is my summary slide. Checkpoint inhibitors are firmly established as a standard of care in advanced bladder cancer. Too many trials to cover, but I think I've covered a few of them that demonstrate that. It improves survival and is associated with a better quality of life as monotherapy in the second-line setting. I was not able to cover the quality of life data, but in both Keynote-45 as well as in Vigor-211, the quality of life PROs that were collected from patients show that patients do have a better quality of life as compared to single-agent chemotherapy. And then completed and ongoing trials are helping us refine the role for anti-PD-1 therapy in the first-line setting. We know that right now, based on the current label, it's either monotherapy in PD-L1 positive patients or platinum ineligible, which means they're not eligible for any platinum-containing chemotherapy. And then recently completed trials in Vigor 130, Javelin 100, and ongoing studies such as Keynote 361 are going to better define the role for concurrent platinum-based chemotherapy. I will caution that when I say completed, which means that the enrollment is completed and at least the primary analysis has either been released in a presentation or in a press release. Javelin 100, which I have not talked yet about, is a maintenance study of avelumab, which is a PD-L1 antibody after patients achieve at least stable disease following 4 to 6 cycles of platinum-based chemotherapy. We are going to be seeing this data presented in a couple of weeks at ASCO annual meeting in the plenary session, and many people are excited about this. And essentially what we need to understand is, should we use it in combination with chemotherapy up front, or should we wait for patients to achieve a response and then use it as maintenance therapy? And I call maintenance therapy as kind of like early second-line treatment. Intervene earlier with immunotherapy for better outcomes. So with that, I'll close, and I'll close with a question real quick. And hopefully we'll generate some discussion amongst our panel members. So we have a 78-year-old gentleman. He has a 45 pack year smoking history. coronary disease, hypertension, chronic renal insufficiency, and COPD. And he's presenting with frequency, dysuria, and gross hematuria. He ultimately is diagnosed with a locally advanced urothelial bladder cancer. He has multiple liver and lung metastases. His ECOG performance status is 2. His estimated creatinine clearance is 39 cc's per minute. A PD-L1 expression level is assessed on a biopsy of his tumor tissue from the lung, which demonstrates a CPS score of 30 and an IC3 level, which is actually, just for reference, greater than 10% expression of PD-L1 on the tumor. So both were able to be assessed. So which of the following is the least appropriate treatment option for this particular patient? So our choices are pembrolizumab, carboplatin gemcitabine, cisplatin gemcitabine, atezolizumab, or best supportive care alone. So before I answer it, Dr. O'Donnell, what do you think?
Sure, maybe I can take a couple of them and in reverse and cross them off. So clearly this patient is not cisplatin eligible, so answer C would not be an option as creatinine clearance is too low to permit cisplatin use. I would also say that carboplatin gemcitabine here is probably not in this patient's best interest. There are data that you actually referenced that patients who have, sort of two poor prognostic factors, that being a low creatinine clearance here and a performance status of 2, that those patients actually have quite a bit of toxicity from carboplatin-based therapy and really do not show significant benefit. So I would eliminate choice B for this patient. Best supportive care alone is always an option, but this patient probably deserves the chance at some type of therapy. And so I think A and D, the immunotherapies, would be equivalent options in this case, given the high PD-L1 expression.
So I thank you. That was actually a very perfect discussion. One of the important things that you highlighted again is that CarboGem in the EORTC 30986 study, which compared MKV versus GemCarbo, the patients who had PS2 and impaired renal function actually have very, very short survival. So you're absolutely correct. And so that would be probably a little less attractive, but I think the clear answer that is the least appropriate is probably cisplatin gemcitabine, because this patient is very likely to suffer worse outcomes and is not eligible for cisplatin, a large part of it driven by the impaired kidney function. Dr. Kamat, I mean, you often don't see these patients once we start them on medical therapy, but this does fit the classic patient who's presenting with gross hematuria and often gets diagnosed, and also the protoplasm of these patients. Can you give me a little perspective on where you see these individual treatments for this particular patient?
Yeah, no, absolutely. I mean, I agree with obviously the discussion that you guys just had. For this patient, really with the liver metastases, as you mentioned, even the IOs are not going to provide this patient with as good a response as we would like. So Peter's going to talk about the ADCs and the other paradigms for this patient. But amongst the choices that you have, absolutely agree that the cisplatin would not be something you would use for these patients. And that would be the least, since you did say least appropriate, C is the least appropriate.
All right, terrific. All right, so with that, I'll close and I will hand it off to my colleague, Dr. O'Donnell, and he's going to be talking to us about the efficacy and safety of ADC and enfortumab vedotin in patients with metastatic urothelial cancer. So take it away.
Great, all right. Okay, very good. Thanks, Dr. Balar. And I'm happy to talk about the newest kid on the block, which is the newest treatment available for metastatic urothelial cancer, enfortumab vedotin. These are my disclosures. And I will mention at the end of this talk some clinical trials that are ongoing, which obviously indicate off-label or non-FDA approved indications at this moment. All right, so I'm not going to repeat a lot of what Dr. Balar so nicely covered, but I do think it's important when we think about these new drugs and the efficacy that they're showing, that we have it in the context of our standard therapies up until now. And I like to joke that it really does seem like a long time ago, and perhaps in a different galaxy of therapy, when our traditional tools were first approved, and that is platinum-based therapy. You can see it was in the mid-'80s. In the late 90s, gemcitabine was shown to have activity, and of course, about 20 years ago, gemcitabine, cisplatin, and MVAC were shown to be equivalent in a head-to-head phase 3 trial for treatment of metastatic urothelial cancer. The important point here is that response rates for these agents are only on the order of 50%. So half of patients will have actual tumor regression. Another third will have stability of disease. But clearly, these are not cure for most patients. Median progression-free survival times are around 7 months, and overall survival about 14 months. Now, as Dr. Balar mentioned, we have 5 immunotherapies that are now approved on the market. With these 5 agents and the newer agent erdafitinib that was recently approved, and then enfortumab, which I'm going to talk about, it's amazing to think that we have 7 new approved therapies in the span of less than 4 years. All right, so the current treatment paradigms, as Dr. Balar recapped, if your patient is cisplatin eligible in the frontline setting, you're probably going to be using gemcitabine cisplatin. If your patient's cisplatin ineligible, you're thinking about an immunotherapy if the patient has PD-L1 high expression, or gemcitabine carboplatin if your patient has reason to need a cytotoxic. If your patient's completely chemotherapy unfit, you have the immunotherapy option. And then in the platinum refractory setting, we have the 5 immunotherapies with pembrolizumab having level 1 evidence. So what are the options now in the post-platinum, post-immunotherapy space? And the basis for the approval of this newest agent, enfortumab vedotin, was summarized in the Journal of Clinical Oncology last year in the paper, the phase 2 trial that supported its use. I will recap that trial and the data from that in the ensuing slides. First, to talk about the mechanism, because this drug does have a unique mechanism of action compared to all of the other drugs that have been approved for metastatic urothelial cancer. So it is an antibody-drug conjugate. There are other antibody-drug conjugates on the market already for other cancers, obviously. And so an example of what an antibody-drug conjugate is, a schematic representation is shown on the left. This has the antibody portion, and then linkers to monomethyl auristatin E, which is a tubule-disrupting cytotoxic agent. There are actually 4 molecules of MMAE attached to each monoclonal antibody molecule here. The monoclonal antibody, importantly, is targeting the binding of Nectin-4, which is highly expressed on the surface of most urothelial cancers. And so the idea on the right here of the mechanism of this drug is for the antibody to recognize and bind Nectin-4 on the surface of a cell. It internalizes into an endosome where there is degradation that then occurs in lysosomes with the subsequent release. The linker molecule degrades, and then there is release of the MMAE molecules, which then undergo the tubule disruption mechanism. So the phase 2 study that I alluded to, published in JCO last year, otherwise known as EV201, it had a screening of patients that had previously been treated with both the platinum agent and a PD-1 or PD-L1 inhibitor, and that is in cohort 1, which is the data that have been released. The top portion of this figure describes that cohort. There were 125 patients ultimately analyzed in this cohort, and you can see they were treated with enfortumab vedotin, which is given on a schedule of every week for 3 weeks in a row, with the 4th week being off at a 1.25 milligram per kilo dose on days, again, 1, 8, and 15. The primary endpoint of the study was the overall response rate, and then secondary endpoints, of course, were duration of response, progression-free survival, and overall survival. So the 125 patients, as I mentioned, the demographic characteristics were that the patients were a median age of 69, although quite a large range of ages. The primary tumor for these patients was predominantly in the bladder, as we would expect, but there was a third of patients that had upper tract primary tumors. Importantly, I think for our consideration of the data that we're going to look at, 40% of these individuals had liver metastases. And you can see this was a heavily pretreated population with the median number of prior systemic therapies being 3. And then also important to point out, since all of these patients had to have previously been treated with an anti-PD-1 or PD-L1 agent, you can see that if the population had what we would expect for a response rate to the prior immunotherapies. 80% of the patients were non-responders to immunotherapy, which tracks very well with what we would expect for general responses to immunotherapies. So I mentioned Nectin-4 being the target here. Nectin-4 does not have to be tested for in order to use enfortumab vedotin under the FDA approval, and that is because almost all urothelial cancer patients will express some degree of Nectin-4, and actually most patients express it at a high degree. This is a plot showing the H-score, which is a measure of the amount of expression on the y-axis, and each patient shown as a bar on the x-axis, and you can see that Nectin-4 was detected in all patients in this cohort. All right, so here's the primary efficacy data from the JCO article. You can see that the overall response rate on the left was 44%, with 12% of these patients having complete responses and 32% having partial responses. And I'll just pause to remind us that the first slide that I showed, right, our response rate to frontline cisplatin-based therapy is about 50%. And so in a third line or beyond setting, we're seeing a drug here have very comparable activity from a response rate standpoint. From a standpoint of any patient showing some degree of tumor reduction, 84% of the patients had some shrinkage of their tumors. I think that's evidenced well on the right-hand part of the slide, which is a waterfall plot. Each patient is an individual bar on this plot. The y-axis is the change from baseline in the amount of tumor size, and you can see the dramatic number of patients here showing some degree of tumor regression. Again, on the left, the summary statistics about this trial. So in those people who did respond, the median duration response was over 7 months. And for the whole cohort, overall, the median progression-free survival was just under 6 months, with a median overall survival, again, in this third line space, over 11 months. And these data really do mirror well another data set that we have with enfortumab, which was just recently published, the phase 1 study of enfortumab in 155 refractory urothelial cancer patients that showed very identical efficacy rates. Now, we would start to wonder, is this treatment working for, different subgroups of patients with urothelial cancer? And this slide shows that well, that all of the subgroups really responded very favorably to enfortumab. I'll highlight just a few of these. You can see that the response rate in individuals who had liver metastases, which I think is really one of the most important prognostic considerations in a patient with metastatic urothelial cancer. Traditionally, a patient with liver metastases would have a very short survival, a very poor prognosis, and you can see that enfortumab worked quite well in these individuals as well, with comparable response rates in patients with liver metastases to those who did not have liver metastases. You can see that the response rate in patients who had fewer prior therapies compared to those with many, 3 or more prior therapies, was again very similar here. And perhaps another point to make about the prior immunotherapy, it did not seem to matter whether the patient was a prior responder to immunotherapy or not. Those patients had very equivalent prior responses to enfortumab in this setting. So let's talk about tolerability. Obviously, the drug had very exciting efficacy data, but we have to be able to give this to patients in a way that's safe. And so this describes, again, the tolerability data from the 125 patients published in the JCO article from the EV-201 study. I'll highlight a few of these points here. So the number of individuals that had grade 3 or greater treatment-related adverse events was about half of the population. And so remember, this is not an immunotherapy. This is an antibody-drug conjugate, and so it's coupled with a cytotoxic portion. And so we are going to expect patients, as I describe it to my patients, to have tolerability that's somewhere in between what we'd consider our traditional cytotoxic chemotherapies like platinum-based therapy and immunotherapies, which we've all gotten used to being quite well tolerated in our patients. So this is somewhere in between is how I think about it. You can see the most common treatment-related adverse events, those seen in 20% or more of the patients, fatigue being the most common. This drug does cause hair loss in a large number of individuals. There are taste changes and appetite decrease in some patients. And then you can see neuropathy, peripheral neuropathy being the next toxicity that's mentioned here, and I'll talk about that in detail. So this perhaps should be expected because of the tubule disruption mechanism of this drug, and I think it's very similar to what we see with use of taxanes in this setting. The development is very similar and has a similar time course with this drug. The other toxicity that I'll point out on this slide here is the maculopapular rash, which was noted here at any grade in about 1 out of 5 patients. And I think it's an important toxicity to mention to your patients, and I'll talk more about it in just a moment. So there's 3 key toxicities that I want to expand upon from the prior slide, and one that wasn't mentioned on the prior slide. So the first is the peripheral neuropathy. As I mentioned, it was 50% at any grade in these individuals. A small number had grade 3 or higher grade. There was no grade 4 events. The sensory peripheral neuropathy was the most common type. Of patients that had peripheral neuropathy at enrollment under the trial, about half did not worsen. And there have actually been analyses looking at who develops peripheral neuropathy with enfortumab vedotin, and it appears to happen in individuals who had pre-existing peripheral neuropathy. Remember, many of these patients received prior cisplatin-based therapy. And then it also seems to happen in patients who did not have prior platinum-based therapy. So it seems to be a treatment effect of enfortumab directly. 76% of patients had resolution or events ongoing at a low grade at the time of last follow-up, so it appears to be manageable in a large number of the patients. And I've been asked, are there ways to try to mitigate this? In my experience, the peripheral neuropathy really does seem related to the time on treatment. So most of my patients who have been on enfortumab for 4, 5, 6 months are going to start to develop some degree of neuropathy. I have used agents like duloxetine, which has an ASCO designation for treatment of chemotherapy-related neuropathy, and I've had some success with use of that. Holding the drug, holding enfortumab, and allowing neuropathy to resolve is somewhat of a challenge because, as we all know, neuropathy often lags behind the time of treatment. So even when a patient comes off of enfortumab for a small dose delay, oftentimes the neuropathy continues to worsen for some period of time because of this time lag effect. The second toxicity I want to expand upon a little bit is the rash. Patients have multiple different types of rash here with this drug. You can see it was about half of patients having any grade, with 12% having grade 3 or higher rash. There was one case of a grade 3 Stevens-Johnson syndrome that was reported by the investigator. But in general, the rash here is a maculopapular rash. In many of my patients, it looks like a bad sunburn, in fact. Even the rash will go through different degrees of healing where, like a sunburn, it will become dry and then the skin will start to peel. There are some patients that will have blistering with the rash here. The one, I think, positive part of this is the rash tends to respond very well to short dose holds of the drug. Even a patient coming off of enfortumab for a week or two will notice the rash dramatically getting better. The one point I'll also make here is that we as oncologists are used to now managing immunotherapy-related rashes. This is a different type of rash, and I did not find in my own experience that it responds to topical steroids like would be our reflex for treating immunotherapy-related rashes. We haven't found one great treatment for the treatment of this rash in most patients. It takes a tailored approach using different agents, including barrier agents, for your patient to find what might help the most. The last toxicity I'll mention is not one that I've mentioned thus far in this presentation, and that is hyperglycemia. It occurred at 11% in any grade in the EV201 trial. 6% of patients had grade 3 or above. This is a toxicity for the mechanism where the mechanism is not well understood at this point. It does seem to be clearly a treatment-related effect from the drug. It happens in patients who do not have pre-existing prediabetes or diabetes, and in fact, this drug EV seems to cause almost a pre-diabetes type syndrome in some of these patients. It often happens very early on within the first few weeks of a patient starting enfortumab, and so you have to be very cautious about checking your patient's glucose levels. In fact, the FDA label approving this drug does require that a patient have their glucose checked on the day of treatment, and that you know the value before administering EV, and if the patient's glucose is above 250, that you should not give enfortumab on that treatment day. The other good point about this toxicity, if there is one good point, it responds very well to holding enfortumab vedotin. So the patients who I've had where they've had hyperglycemia from the drug, the hyperglycemia resolves quite quickly with holding EV. So the approval, just to state it here, the FDA approval was for adult patients with locally advanced or metastatic urothelial cancer who had previously received an immunotherapy and a platinum-containing chemotherapy, either in the neoadjuvant setting or in the metastatic setting. We're, of course, also awaiting confirmatory data. This was an accelerated approval, and so there is an ongoing phase 3 study comparing enfortumab to dealer's choice taxane-based chemotherapy in the refractory setting. This is the EV301 trial. It enrolled 608 patients, and the patients were randomized to either enfortumab vedotin or a taxane, or in Europe, vinflunine. All right, I'll mention just to close here a few of the ongoing trials where we're now trying to look forward for the field, and that is, could we start combining enfortumab with immunotherapies to capitalize on really the impressive activity that we've seen for both of these classes of drugs? And so there is one study that has been presented now. The most recent presentation was at GU ASCO earlier this year. It's a frontline study where patients were being given the combination of enfortumab with pembrolizumab in previously untreated metastatic urothelial cancer. The data so far are in a limited number of patients. This was 45 patients. You can see the characteristics here. Again, a third of the patients had liver metastases, which I think is an important consideration, again, for this treatment population. And there was patients with multiple different status of PD-L1 expression allowed in this trial. And here's the data presented by Jonathan Rosenberg at GU ASCO earlier this year. And again, the waterfall plot on the left showing this very impressive composite tumor reduction for the cohort of patients, 93% showing some degree of tumor reduction. This seemed to occur in patients with both high and low combined positive score PD-L1 expression. The overall response rate here by confirmed overall response rate was 73%, as you see. And then lastly, from that presentation at GU ASCO this year, and to bring this back to where I started, we have reported data now for this combination in the frontline setting where you can see the median progression-free survival, again, in a single-arm trial and in a cohort that is a small cohort thus far. The median progression-free survival is over a year for this population, and the median, the overall survival has not yet been reached. And so when we think about these data, in contrast to what we first described for cisplatin-based therapy, it certainly is exciting to think about the future for metastatic urothelial cancer. So I'll close with this, that we're already seeing dramatic changes that provide us with new treatment options. And there are, I think for completeness sake, there are additional antibody drug conjugates that are in development. Sacituzumab is an anti-TROP2 molecule that's combined with SN38 that's in development. Oportuzumab monatox is an anti-EpCAM molecule. It's combined with the Pseudomonas exotoxin that's in development. And then there are the antibody drug conjugate immunotherapy combinations that are likely to expand and already being expanded to other settings for the near future. So I think we'll close with this case and open it up to the other faculty as well to hopefully have a good discussion. So this is a 57-year-old male who originally presented with hematuria. A cystoscopy showed a T2 urothelial carcinoma. The patient underwent radical cystectomy up front with lymph node dissection. The pathology showed a high-grade urothelial carcinoma that was involved in one perivesical lymph node. So the patient's stage was a PT3A N1. The patient started adjuvant cisplatin-based therapy, as would be our typical standard in this case. He completed 3 cycles, but unfortunately stopped due to worsening renal function and weakness. And I think that's very common in our experience with the patient's tolerability for adjuvant cisplatin-based therapy. The patient went on observation at that point, as would also be the current standard. And 8 months later, unfortunately, he developed metastatic recurrence with lung nodules and liver metastases. He went to second-line pembrolizumab, received 2 doses of that drug, and unfortunately had rapid progression of disease. And so I'll open it up maybe to Dr. Balar here to talk us through the treatment options at this point. I've given 5 here that maybe you could discuss the pros and cons of.
Sure. Let's just kind of go down the list here. And, treatment with docetaxel, I'd probably be a little reluctant to do that, especially if he had significant toxicity with the adjuvant gemcis that was needed to be stopped after 3 cycles. But importantly, if a patient receives adjuvant or perioperative chemotherapy with cisplatin and is not able to achieve cure, there are data for being able to re-challenge patients with cisplatin probably a year later. However, if they weren't able to cure with in a perioperative setting, I'm less enthused to use it. Similarly, with gemcitabine, carboplatin is less active than cisplatin-based treatment. So while it wouldn't be necessarily wrong to do it, it wouldn't be my first choice. Taxol monotherapy would have been certainly a reasonable option in the pre-ADC era. So after failure of pembrolizumab, before December 2019, this is commonly a drug that we might use. Erdafitinib, I don't recall if the patient actually is FGFR mutant or not. I don't recall that in the case.
We don't know.
Yeah, we don't know. So I would definitely have, and I'm sure you did in the case, is that you're going to send the specimen off for sequencing so you have that information. But if you don't have it, you can't use it. So then it naturally leaves enfortumab vedotin to be the most appropriate treatment for this particular patient. And that's probably what I would choose.
Dr. Kamat, I don't know if you want to add anything to that. Excellent discussion.
And again, Arjun did a phenomenal job, but the FGFR status pending, I presume you didn't mention it because it wasn't either done or not relevant here. And obviously E is the obvious answer. But if you have the FGFR3 status, then you have a option really that you could consider. I think it's interesting, you know, from my perspective, sitting on the non-medical oncology side, we used to joke as surgeons that, oh yeah, the medical oncologist for bladder cancer just needed to know 4 names of 4 drugs. And now that's obviously expanding, right, with the plethora of approvals and studies and things that are being done. So it's great that we have so many choices.
Great.
So in closing, I just want to take a couple moments to thank the faculty for this really engaging discussion and talk that we had. If each one of you in maybe, you know, 10, 15 seconds, just want to share with us your closing thoughts. So Arjun, you?
Sure. Bladder cancer treatment is changing so fast. When I started fellowship and to where I am now, the options that we have for patients is rapidly growing. And I think what we're seeing is the prognosis of patients and survival times are very different today. And we need to show this in data, but I have a firm belief that the prognosis and outcomes of patients today are just dramatically better than we've ever had before. So I'm really excited about the field.
Peter?
I couldn't echo that more. I mean, it's really great to have so many options for our patients. And I think, you know, looking forward, you know, now our task is to learn how to combine some of those therapies to really make further advances in this disease. We can't rest on our laurels here because there still are a large number of patients, right, that we do not cure of this disease. And I think, you know, going back to where we started with this hour, you know, further understanding of some of the molecular drivers of this disease and maybe subsegmenting this disease further, like has been done for lung cancer very effectively, is probably going to allow us to identify those new treatments on the horizon.
Yeah, no, great points. Once again, gentlemen, thank you so much for joining us today. Stay safe and stay well.
All right, thanks very much.